Hey, everybody. It is good to be back. Hey, everybody. My goal every time I do one of these is to avoid the lag time in the beginning where everyone's kind of like looking around and seeing, are we live? Or is it live yet? I think I nailed it this time. Must be the tie. No, I just finished up a shift here at the office, and yeah, looking forward to jumping on and doing some questions and answers. These are my favorite. I love doing these, so really excited to be back on the YouTube channel. So we'll give everyone some time just to join in. Hope everyone's year is off to a good start. Right. What else? As we're waiting for everyone to come in, we just had a team meeting with the crew with 3DMJ. It was great to see everyone and hear from everyone. And we usually do those every couple months. And it's really nice to catch up because we follow each other indirectly on social media. But it's always nice to just check in with everyone and talk about families and things like that. So um, big news, as many of you probably know, Alberto, new baby. So that's huge. Happy for him and Cynthia, of course. So that was awesome. Yeah, really, really cool to catch up with everyone. But today, as the questions kind of guide us to wherever they may guide us, I wanted to kind of talk about just common injuries, common questions that we get or that I get in treating bodybuilders, weightlifters, powerlifters. Because I think if we address some of those questions, maybe it could just better arm everyone out there. If they're going to see a healthcare provider, at least they can bring some good points and ask some good questions when it comes to their own care and their own health. So we got a couple people here joining us. Hey, everybody. Hey, hey. So I guess first thing we could talk about is low back pain. There's a lot of, I guess, misconceptions about low back pain. Not really misconceptions. I guess a lot of noise out there about low back pain. And there was a recent podcast episode with Stu McGill. I think it was on Peter Attia's podcast that kind of got a lot of um, publicity, and which is fine. I think when it comes to someone like Stu McGill, I think if someone were to stumble on his work, I think they would end up better for having found it. I don't really, I think I agree with over 90% of the things that he says. That being said, I've never really dove into his content. I never read his books. All I know is the basics of who he is and the kind of things that he teaches. And I do think that most of what he says is excellent. Um, so, yeah, I think if someone were to be platformed about low back pain, I think he's probably one of the better ones out there uh, for that. But anyway, so some things with low back pain. A lot of times, people will come in and ask and kind of have a bit of fear about the pain, not really know what it is, why it happened. They ask questions about discs. I just hope it's not a herniated disc. I hope it's just a muscle strain and not something serious like a herniated disc. And that is something common. I'm not sure why a herniated disc has gotten to be so scary to people. I guess seeing pictures online, um, and reading things online can make it seem scary, like you have this jelly donut in your spine that kind of pops out and hits a nerve. Um, but herniated discs are not something to be feared. Most of us have them. Research shows us that, geez, over 70%, I think, random people that they sample to do MRIs on their backs have some kind of herniated disc and are not symptomatic. So we can have those things going on in our backs, and it's not a diagnosis. It's not some kind of like getting diagnosed with bronchitis or pneumonia or cancer, where you have a diagnosis, a specific treatment for that diagnosis. Well, first, a test that is reliable to determine the pathology. And then, if that pathology has a research evidence based track to take to recover from it, we don't have that when it comes to these kind of things. We don't have a protocol for a herniated disc at L5. Everyone presents differently. We can have 10 people lined up and they can all have an identical MRI. One person would not even know they had it. Another person would be in a wheelchair because they can't move their leg. Another person would have occasional pain in their back. The other person would have ripping pain down their leg into their foot. All different kinds of presentations when it comes to something like that. So that's why the the finding of a herniated disc on an MRI is not necessarily a diagnosis. It's not going to really change the course of action in the recovery process. And that's a big question to ask with any test is the result of this test going to change what we do to treat this thing? And that's just not the case with something like an MRI that shows a herniated disc. MRIs are great for ruling out red flags, things like tumors, God forbid, right? Something like that. But usually the symptom presentation will lead us to that. Or if they're not responding well to conservative treatment and we think they should be responding better than they are, then maybe it's time to try something like an MRI. But the MRI usually won't guide our treatment. Hey, how are you? Good to see you. Good to see you. Yeah, so that's one of the things with low back pain is people will come in with this thought that a herniated disc is some kind of disease or some kind of pathology or disorder, when really it's just something that we see. Um, it's kind of like marks on a tire or something. Like they're gonna happen as we drive. It doesn't mean we have to replace the tire. Sometimes you hit a rock or something and it makes a little scuff on the tire, but uh, it's functions completely fine. You don't have to go replace it. The other thing when it comes to back pain is posture. Hear a lot about posture. If you're interested in a bit of a deeper dive on posture, I did a video with Jeff Nippard. Geez, maybe 2 years ago now, and he does a really good job. Jeff Nippard and Sam Spinelli, and that was a pretty really good video. Awesome to be on his channel. He's just such a great guy on screen and off, I guess you could say. So that was a really good video on posture. But basically, there is no good or bad posture. You could slouch in a chair, and that will feel good for a little bit, and then you could sit up straight, and that would feel good for a little bit. You could lean on your side, switch to the other side. You can put a box under your table or desk and prop your feet up on the box. Put one foot up, the other foot up. You put a tower roll behind your back to support your back. All those things can help. The important thing is that you're moving and you're changing your position. So you don't have to walk around like a statue or like a robot. That's going to get uncomfortable eventually. So yeah, the important thing is that we're moving in and out of different postures. And it could be something very simple, like I said, putting a box under your desk, putting your foot on it, or putting a small towel behind your back. Take a break in my monologue because we got some questions here. So that's the main point of me being here, is to answer your guys' questions. And then if we don't have any questions, I'll continue talking about the lower back. All right. Let's see. What exercise selection would you choose to train triceps when you keep getting elbow pain whenever you choose overhead type stuff? Great question. Um, so when it comes to pain, you can kind of think of exercise selection almost in like a hierarchy. And pain kind of overrides everything. What I mean by that is, in normal circumstances without pain, you want to put the muscle in the fully lengthened position, or at least in some kind of lengthened position. As we know, you want to try to emphasize that fully stretched position. For the triceps cross two joints. So they cross your shoulder joint and they also cross your elbow joint. So, in order to stretch the triceps, you want to bend your elbow, right? Because now it's getting stretched around the elbow. But you also want to lift up your shoulder because now it's getting stretched here and it's getting stretched here. So that's the fully stretched position of the triceps. Your elbow's going to be overhead and your arms in the back like this. The problem is, while although the fully lengthened position is excellent for hypertrophy, it may not be great for pain. And if you have a sensitive elbow, that fully lengthened position could be pretty sensitive and pretty provocative. So I would just reverse engineer that setup. So I'm not sure if you chose the overhead tricep extension to take advantage of that fully lengthened position, but in the case of elbow pain, one option could be to reduce that stretch. So instead of doing an overhead tricep extension, maybe just do a cable press down where your arms are at your sides. And so basically in that position, the tricep will be on slack at your shoulder, and then it will be stretching and contracting at your elbow only. You're still going to get a heck of a tricep stimulus, but it's going to be less, I guess, kind of pressure or less sensitive on the elbow potentially. And you're not going to lose that much in the hypertrophy realm because uh, what's worse for hypertrophy is fully stretching the muscle under load, but making your pain worse because then you can't train after that. So the little, I guess, drop in hypertrophic stimulus of not getting the fully stretched position is not going to be a comparison to doing the exercise pain free. If that doesn't work, you can try isolating. Um, I'm sorry, isolating. What am I trying to say? Lowering the load. You could try limiting range of motion. So sometimes, even if you put it on slack at the shoulder, maybe that fully bent position of the triceps, maybe that's still too sensitive. So then maybe you do your tricep extension up to here, and then maybe just come back to about 90 degrees at your elbow, and then contract back to about 90 degrees, and then contract. If you do that, believe it or not, Mike Israetel will not pop up out of thin air and say that you're not getting a full stretch on the triceps. Um, you could just tell him if he did appear, you can just say, Dr. Mike, I have pain in my elbow, so I'm doing this. And he would say, oh, that makes sense. Good job. Keep training. And then he'd disappear again. So yeah, try limiting the range of motion, even in the not lengthened position. BFR is a great option for elbow pain, whether it would be with triceps or biceps. BFR is a great way to limit the load, but also get the same training stimulus. Yeah, try those, and I think that should at least get you on the right path. If those don't work, then maybe we can dive in a bit deeper. And I'm always available if you want to shoot me a message. We can continue the conversation. All right. Let's see. How do you handle someone with patellofemoral pain and knee cartilage issues? Very common thing that I see every day with weightlifters, with everyday people, with athletes. Not that weightlifters aren't athletes, but in my mind, I'm thinking like high school athletes, like college athletes that run track, football, soccer, all those kind of things. Um, so, how do I handle those patients? Pretty much whatever comes in that door, we're going to see, we're going to rule out red flags. So, in the knee, usually we don't have any kind of red flag unless there was some kind of trauma, like unless they took a hit in a game and their knee took a nasty turn and now they can't put weight on their on their leg. That would be a red flag that we'd want to get checked out. But usually those kind of patellofemoral pain issues where they just kind of progress over time and sometimes they'll go away, sometimes they come back, and then it just kind of gets worse and worse and worse. with that, what we're going to do is see if we're going to calm it down or build it up. So if it's really sensitive and the person's limping in front of me, then we're going to say, okay, we're going to lean way more toward the calm it down stuff. If someone comes in, they're walking fine, they can squat, they can deadlift, uh, they can leg press, then but it only hurts when they drive in the car or something like that, or it only hurts with deep rear foot elevated split squats. That person, we're going to lean more toward building it up because it's not super sensitive, so we don't have to do too much of the calm it down stuff, but we still want to build that thing up. The way that we build it up is by progressively loading it and gradually exposing it to those kind of ranges of motion that cause it pain. So knees over toes guy, I don't follow his stuff, but I know that he is a big proponent of deep knee flexion. So things like split squats, right? He's got that one leg forward, goes real deep into that knee flexion, like calf to hamstring. That's his thing, right? Like he always that's what he always puts videos on up and stuff like that. I like that. That is exactly what we want to do. I think it gives a message that we shouldn't be afraid of the painful movements or the painful ranges of motion. We want to go in there gradually. I think if there's one thing, again, I don't follow his stuff, so I shouldn't say, but I think if there's one thing that I would do if I were a knees over toes guy is, and he may do this, I'm not sure. I would like to see progressions to those positions because not everyone's going to be able to just go into a deep squat like that or a deep split squat. So if someone has pain with bending their knee, we're going to work from the top down. So if squatting hurts their knee, then we're going to try lowering the load a little bit or lowering the range of motion a little bit. Sometimes, or most of the time, when it comes to true patellofemoral pain, it's depth, it's deep knee flexion, deep knee bending that causes the pain. So most of the time, we'll limit the range of motion. So put a box behind them. We could also try a different exercise. So if squatting hurts, maybe we'll try leg press. Sometimes just a different position, more stability um, helps with the pain. So we'll try a different exercise perhaps. And then what we would do, we would have some way to get the quads a stimulus. And then we would have our kind of exposure sets. So we'd have our working sets with modifications, whether it's a box squat, leg press, whatever we have to do to get the stimulus in our quads. BFR, excellent for patellofemoral pain, um, similar to the elbow, right? The knee is kind of the elbow of the leg, so responds really well to some BFR. Once we find a way to train it and get a stimulus, then we will add these kind of exposure sets before or after training or on off days. And basically, what they are is some kind of like shadow of the goal exercise. So, for someone like this hypothetical example, what we would use is perhaps a TRX squat to a chair. We would have, say, they get pain at 90 degrees of bending their knee during a squat with the TRX and with the chair, we would slowly kind of inch into that range of motion. Now, it probably won't be painful, just because it's a modified version of that squat. Um, so, do a couple of rounds of those TRX squats to the chair. We're just getting to that 90 degrees of knee bending and then standing up, sinking down to about 90 degrees of knee flexion and then standing back up. And what that's doing is it's exposing the knee to that range of motion under load, just in a different way. So then we would do that over and over and over again and just get that knee used to going in that range of motion and accepting that load. And then we slowly work out of that and we slowly get rid of the chair or use something lower than a chair, get rid of the TRX, and then we slowly work back into our squat. And then the modified exercise that we did to get our stimulus, like the leg press or the BFR, then we would slowly fade that out and fade the other exercise in. So that's kind of the process with patellofemoral pain. And cartilage, I would put in the same category as that. Like chondromalacia, sometimes you'll hear that sounds really scary. All it is just something that they found on an image with the cartilage on the back of your kneecap. Most of us have it. Could be quite painful if it's symptomatic, but we would approach it basically the same way. We would avoid movements that put your knee in deep, deep bending for the time being. We would find a way to load the joints and soft tissues to get a stimulus, and then we would also find a way to gradually expose them to that deep knee bending under load. All right, let's see. Ooh, good question. Have you ever dealt with a female with a hypertonic pelvic floor that wants to get back to resistance training? Anything that you did or you'd expect to work well, and anything that you wouldn't? That is a great, great question. Um, so, when it comes to the pelvic floor, so I'll say this: there are people that specialize in pelvic floor. That's all they do, all day, every day. Um, if you would like, please message me, and I can connect you with some of my colleagues that I know work with pelvic floor every day, and some resources I can point you to. I'm sure they do virtual consults, so reach out, Instagram, anywhere, and then I can connect you with them. I can hold my own with pelvic floor rehab, but I'm definitely not the best resource for that. But just to kind of take it from the top, the pelvic floor, if you think of your torso, you have your diaphragm on the top, you have your abs around the sides, and you have your pelvic floor on the bottom. So that whole cavity kind of works together to keep your organs in place, keep your body stable. Um, and the pelvic floor has a very important job, not only in overall stability of your back and your pelvis, but also controlling urine, gas, bowel movements, orgasm, all those kind of things. When it comes to pelvic floor rehab, usually it has to get stronger. Usually it's weak, perhaps a recent pregnancy or childbirth, maybe like a prostate issue for men, or just aging. In women, sometimes they'll get some urine that slips out with laughing or jumping. So usually we're working to strengthen the pelvic floor. And what we would usually do is just like anything else, we would progressively load it. Um, a hypothetical progression for pelvic floor uh, strengthening would be lying on your back, knees bent up, and just pulling up on your pelvic floor like you're kind of holding in gas or urine, holding it for a couple seconds, and then relaxing. Slowly ramping it up, contracting, slowly ramping it down. Could also do like quick bursts, right? Like contract, 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 contract. Do those for sets and reps. So what that's doing is putting your body in a real relaxed position, just trying to get you connected to the pelvic floor and just kind of getting it to respond to those contractions. After that, then we can progress it. So we can maybe lift one leg in the air and do it like that. And then maybe lift two legs in the air and do them like that. Maybe we then stand up and we do that pelvic floor contraction in standing, which is way different because now gravity is pushing everything down and your pelvic floor has to hold all that up. Um, you can do pelvic floor contractions with things like step ups or squats. And that's how we would kind of progress someone with a weak pelvic floor, maybe some leakage that's happening during training, and then we would get them back into squatting and deadlifting. And yeah, but the thing that you're talking about is hypertonic pelvic floor. So what you're talking about is something that's not quite as common, but a situation where the pelvic floor needs to relax. In that instance, um, this is definitely where I'm not an expert, but you can hit it with the basics, some deep breathing, some focused relaxation of your pelvic floor, That could sometimes help, but this is where manual therapy comes into play, and this is where I step out of play. There are therapists that will manually go in and release muscles inside the vagina or the rectum, and they just like a muscle on on the outside of the body, and they'll release them. They'll help them relax a little bit, and then you follow up with your exercises. So just like foam rolling, it will provide a short-term relief of some tightness, of some pain, and then it will allow you to do more as far as training goes. So that's kind of as far as I can go with that, but I can definitely connect you with some people that can help. All right. Does a pec tendon tear need to be treated surgically if someone wants to compete in bodybuilding? Does it change if it's a pec major versus pec minor tear? So, when it comes to surgeries, it's always a question of what are your goals, right? And so, if someone came in here with a pec tear, and it's a huge spectrum of pec tears. You can have someone who, like on a crazy YouTube video where someone's doing a bench press and pop, you just see the pec just burst off the shoulder or off the sternum. That's pretty bad. That I would say probably going to need some surgery. But other times it's just a small tear and you could have some pain. Maybe you went too deep on an exercise and you felt the sharp pain in there. You got it ultrasound or MRI and they found a tear. But you're able to lift your arm, you're able to do all your activities of daily living. Training is a little bit limited at the moment because it was still fresh, but overall, like with time, you're able to continue on and lift heavily. Um, so there's a spectrum, right? There's the one guy who pops his tendon on YouTube, and the other guy who just has a small tear and is able to compensate around it, and you never look back and you forget which side it was on in 5 years. Um, the process of figuring out if someone is a surgical candidate would be the following. We would work conservatively first. So, number one, let that thing heal. If there's any bruising, if it's painful at rest, that's something we want to let calm down before we go trying to build it up. So, first and foremost, calm it down if it needs to be calmed down. Once it is calmed down, then we can start building it up. And the way we do that is start from the bottom. Start with some gentle isometrics, some limited range of motion, pressing movements. Make sure we get overhead range of motion back if it was restricted. External rotation is very important with that kind of injury. And we would slowly work back into the exercises and activities that that person wanted to do. If all goes to plan, great. It's a couple weeks to months, and we gradually expose that area to some load, and it gets better and bounces back. Um, One thing before I move on, when it comes to range of motion, always make sure that you compare to the other side, because if your good side moves like this, okay, let's see, if the good side moves here and the bad side moves there, maybe you're at your full range of motion. So don't go chasing like quote unquote full range of motion because it's different for everyone. And you can use the opposite side to determine what your full ish range of motion is. Um, so in that example, the person would kind of get back to what they're doing conservatively. They had to modify their training a little bit, take a little time off just to help it recover, and they're back in action. If, however, we try to calm it down and we just hit a brick wall, we can't do anything to calm this thing down. We're doing manual therapy, we're doing electrical stimulation, we're doing ice, we're doing heat, we're doing rest, we're doing anti-inflammatories, and that thing is just pissed off. Then I would send back to the doctor and perhaps get some more imaging, maybe an injection in there, some cortisone, just to kind of calm it down, and at least in the short term, just to allow us to do more in rehab. And then if that doesn't work, then perhaps we move on to the next step, and that may be a surgical consult. So I think unless it's like the YouTube crazy person, you definitely want to exhaust all your options before you go into something like surgery. Now, your question mentioned bodybuilding. Um, if the pec tear is significant enough that you notice it, like you notice a divot in your pec, and that's something you want to get done for cosmetic reasons, that's a different conversation. That's that's up to you. I don't think you need to do that. It depends on how far you want to take this bodybuilding thing, right? Is it worth going into surgery just to have somewhat of a symmetrical pec? And there's no guarantee it's going to look perfect when it's done. It may have some scarring. It may even be worse after the surgery. So yeah, I would. And also, there was the Mr. Olympia. I forget how many years ago it was when Jay Cutler was competing and he had a torn bicep. The bicep literally was like torn. Some of you remember it. I think it was torn from the elbow up or from the shoulder down. I forget. But he competed and he hit his front double bicep and like just black and blue, like the muscle was like shriveled up, but you still didn't notice it unless you really focused on it, like under the lights, the tan, all the shadows, like the way he positioned himself. You couldn't even really notice it unless you were looking for it. So even in that drastic instance where the bicep was ripped off the bone, um, he was still up there with the best of the best. So yeah, I don't think you have to get it just for the judges in a bodybuilding show. I think it would be highly dependent on how the recovery is going, what your goals are. Um, yeah, I think that's probably the best approach. Yeah, my pleasure. My pleasure. Thoughts on recovery from costochondritis? Yeah, uh, that is that's kind of like chondromalacia. Um, you it has a scary name, but at the end of the day, it's really just pain. So you want to make sure that number one, you rule out red flags, um, and then you find what hurts it, find what makes it better, and determine if you're going to calm it down or build it up. If you're going to build it up, figure out what movements you want to get back to doing, slowly and gradually work back into them, and yeah, monitor symptoms throughout, and don't be in a rush. Let that process respect the process, and if expect flare ups too. Don't expect a clean trajectory of recovery. Unfortunately, we do have times when it just is painful for no reason. Um, so it doesn't mean you did something wrong. Doesn't mean that you took steps back. It's simply just part of the process. So yeah, expect the ups and downs, but also expect the trend to be moving in the right direction. How were you diagnosed with that? And how did it all start? And how are you feeling now? How long has it been? I'm interested. Just if you have any more info. What can we do if we have neck pain and tight neck after Romanian deadlift, and it gets worse with back exercises? Okay, so first, I would like to know like how long you've had it for. Um, that would be helpful, and then I would want to know. So you said after Romanian deadlifts. So am I correct in thinking that when you're doing the movement, it doesn't hurt? It's only afterwards, or do you get the pain as you're deadlifting? That's good to know as well. Does it happen at a certain depth of range of motion? Does it happen when you get really, really deep? Does it happen at a certain load, like when you're just holding the weight in your hands and maybe you're tensing up the shoulders to hold the weight and stabilize yourself? Is it that? Is it when the weight gets to a certain point? Those would all help us. Um, I would also want to know what the warm up is like and where in the workout the Romanian deadlift is. This way, we can see maybe we just need to loosen up the neck a little bit. We the neck is not something we typically warm up. I know I don't. I don't recommend it to people. But if you're having that stiffness and that pain, maybe a neck warm up could be good. Also, some gentle neck stretches in between sets of deadlifts. So if it's sore after deadlifts, maybe just the accumulation of the of the sets and reps after reps after reps, maybe that just makes it tight and painful. So in between sets, if you imagine like set number one, you have like this pain threshold up here. So everything under it, we don't feel pain, and everything above it is when we feel it. So you have like you're doing your sets, like maybe you're doing 3 sets. So like set number one, set number two, set number three just kind of like takes us over the edge. Um, what some stretching or some like foam rolling kind of mobility stuff, 10-second like kind of things in between your sets. What it could do is if it's like set number one, and then it will like you kind of go back down. Set number two, and then kind of go back down. Set number three, kind of go back down. And then you have all this space here now to continue your workout, maybe without pain. And over time, the more that you do that, the less it will get kind of bumped up as you do your lift. So that's something I would consider. I would kind of answer those questions that I asked at first, and then think about maybe doing some neck warm up. So a easy thing would be to lie on a foam roller. The foam roller would be going this way and around about chest height. Support your head and just extend back over the roll. That could be great for your neck and your mid back. Could do some of upper trap stretches. So make sure your shoulders are nice and relaxed. Tip your head nice and gently to one side. Deep breaths. Tip the head to the other side. Deep breaths. That can help. Seems simple, but those little things can kind of help before or during the deadlift. Lean into things like heat and ice after training. That can always help. And with the back exercises, I would ask pretty much the same questions. And if it's only afterwards, then I would suggest maybe um, doing those kind of stretches in between the sets. I would also think about exercise selection. So when it comes to exercise selection and this neck pain that you're talking about, the Romanian deadlift and back training is not really direct neck work, but it for sure engages your neck. So with the deadlift, perhaps limit the depth of the range of motion. That may help. With back training, perhaps limit the stretched position or the fully contracted position, just because at the fully contracted position, perhaps it's that squeeze like back here is just kind of contracting like your upper traps into your neck a little bit, or leaning forward like a big stretch. Perhaps that's doing it. So experiment with the range of motion too, and see how they all feel. So yeah, I would try adding in those stretches. I would try limiting or modifying rather the range of motion and see how all that feels. And then we could always dive in a bit deeper if you want. Feel free to message me. But that is, yeah, that's where I would kind of start and see how that feels. I would also want to know, is there any numbness, tingling, pain that goes down to the arm, or is it all isolated to the neck? That's important too. If you have any of those symptoms, um, I would highly recommend that you go see a healthcare provider. This way they can get those nerve symptoms out as soon as possible. Oh, good clarification on the costochondritis. Was diagnosed by a chiropractor, saw them for 3 months. Heat, scraping, cupping, electric stim, and not training chest helped. Okay, definitely a fine option. So the way I would look at that is it was pretty flared up. Must have been pretty darn pissed off because the treatment for 3 months was heat, scraping, cupping, and electric stim, and not training the chest. So I'm glad that helped because that must have been pretty bad. Um, the uh, the scraping, the cupping, heat, uh, electric stim, those are all things I would throw at it to calm it down. So that seems like it was pretty flared up, but I'm glad it all worked. And then how did you gradually get back into training after it was calmed down? That's a good. That's what I would like to know too. How did you get back into it? So once the Cairo did his or her thing, calmed it down, didn't train chest. Now it's feeling great for a week, for 2 weeks. Now what do we do? How do we get back into the gym? That's usually where I would come in, but I would love to see how it went for you. So the neck situation there, it hurts afterwards and it's isolated. Okay. So then, yeah, I think you could try to do those just gentle stretches in between sets. Um, the foam roller one, you don't have to do in between the sets. Just do that as a warm up, maybe right before you grab the bar or grab the dumbbells. What else can help with that? That's not a bad place to start, honestly. Um, what else? And then you could, like any other pain, if that doesn't work, you could try reducing volume. Um, if it's been there for a while, then that's one thing. But if it just kind of came up, then maybe I would ask if your training changed at all. Have you recently pushed it with volume? Have you pushed the intensity? Maybe it's just a response to the novelty of the training. Then in that instance, I would say just don't change a thing. Just ride this phase out. And then if it's a temporary kind of cycle that you're running, then it'll probably go back to its normal place once the push in intensity or volume gets better. But we can't forget about just volume and intensity, and those are two factors that we can modify. And it's good that it's isolated and not going down your arm. That's important too. With that example of the stretches in between sets, how it kind of like comes up and then goes down, then comes up and then comes down, and doesn't ever really break that barrier. That is something that I use a lot for like tennis elbow and golfer's elbow. So medial epicondylalgia and lateral epicondylalgia. Medial is the inside of your elbow, and that is golfer's elbow. And lateral is the outside of your elbow, and that's called tennis elbow. Um, what I do with those, sometimes people will say that it hurts when they wake up in the morning. If that's the case, I recommend a cheap little Amazon $7 night splint. So basically, the splint wraps around the wrist. There's a metal piece in the splint that sits just like this on the hand. And then when the patient is sleeping, they can't really move their wrist into flexion, into bending it. Why is that important? Well, all the muscles that bend your fingers and bend your hand, they sit right here. They all insert right here on that medial epicondylitis, epicondyle, and all the muscles that pull your hand back and extend your fingers sit right on that lateral epicondyle. So at nighttime, sometimes people will kind of get into this position and sleep like this, not knowing that they have a low level contraction in their hand, in their fingers, for 8 hours, or if you're like me, 4 hours and 45 minutes. That's a whole nother story, though. Any dads out there with young kids? Uh, no, it's good. We adapt and we push on. Um, so the splint at night, if you don't have the splint in this example, and someone sleeps like this, that means that these muscles are contracted throughout the night, and these muscles are stretched all night. Um, if that's happening, then say this is our pain threshold to when we feel pain, and that all night it's kind of like creeping up, creeping up, creeping up, and then maybe you like wake up here, wake up, start your day, sun's out, ready to take on the world. You go to open your bathroom door, and zoop, goes right up, and then you have pain in your elbow. So what the splint will do is prevent that. So instead of waking up here, maybe you'll wake up here, and then you go to open your door and boop, kind of goes up and then it goes back down. And then you go to grab your bag for work and boop, goes up, but then kind of goes back down. Open your car door, it goes up a little bit and comes back down. So it's just this dance of trying to minimize triggering it and getting that little bump in that like sub pain threshold pain model that I'm using here. That's just how I like to think of it. That's not exactly like how it's working, but that's just my frame that I like to look at and how I like to explain it. So similar with your stretches in between your sets, you could potentially lower that little bump in pain potential, I guess. All right. Exercises to avoid with distal biceps tendinitis. Um, common, common diagnosis. Um, it's not always, uh, it's not always uniform. It's not always the same from person to person. You would think that tendinitis at the distal bicep should be the same for everyone. Same structures, and it should respond well to the same things. Um, Not really the case. Some people can have pain in that area and not have anything wrong with their biceps tendon. Other people can have a nasty biceps tendinitis and not have any pain in their elbow, or maybe it hurts around the side of their elbow or in a different spot completely. So I would just call it elbow pain. I would say what exercises to avoid with elbow pain. And in that case, it kind of goes back to what hurts and what feels good. I would venture a guess that similar to the first example that we used here with the tricep, where the person was having pain in the elbow with the fully lengthened position of the triceps, I would imagine that like an inclined dumbbell curl may get some discomfort, especially at the bottom of the range of motion, because you're stretching the bicep at the shoulder when it's back on the incline, and you're stretching at the elbow when it's back on the incline. So that's a pretty much fully stretched position for the biceps. So I would maybe approach that one with care and just see how it's feeling. It's not a bad exercise. I don't think it should be avoided, but if you're going to do it, just ease into it because that's a pretty stretched position for the biceps. But other than that, yeah, I think when it comes to rows, people with elbow pain during rows, I like to recommend straps or hooks. Sometimes that does the trick, believe it or not. Just changing the grip can help. Like lessening the demand of the grip can help. Changing the grip can help on a row. So maybe instead of a instead of the like attachment where you're holding it like this, maybe you get the handles and that allow you to move freely, and now you can do whatever motion your elbow and shoulders kind of want you to go through. That can help a ton. I have limited range of motion with rows with people, and that seems to help too. Limiting load, doing cluster sets like Myo reps. Sometimes it's just time under tension that gets it. So if we do one set and do some Myo reps and put the weight down, and we're good to go, perfect. So I don't know if there's anything I would say to avoid, but just some considerations for modifications that can help. I'd also want to make sure that there's nothing shooting into your hand, like any pain that is going into your fingers, numbness tingling into your fingers, any pain in your neck that may be shooting down. We don't want to be treating a biceps tendonitis, and really it's like a Trojan horse, and it's really coming from your neck, or at least partially coming from your neck. Some stretches you can try to help with it. Um, Arm out straight and pull back on the fingers. Hold for like 10 seconds or so. Hold for 10 seconds or so. Do that a couple times. It's not going to stretch the biceps necessarily, but it could definitely stretch the soft tissues in the area, which can help reduce pain sensitivity. You can try that too. Ice, heat, well, that's going to help too. During an injury, should you be in a caloric surplus or maintenance? Excellent question. Um, it depends. It depends on what the injury is. If you had a total knee replacement and the doctor cut your knee open, cut your bone out, and put a metal knee in your joint and then sewed you back up, I would say let's get out of a deficit. We need all the resources we can get to recover from that. Versus someone who has some shoulder pain with end range bench press. I don't think it matters if that person is in a deficit or maintenance or a surplus. Uh, that would be one of the last things that I go to modify if that were the case. I would go through all the usual suspects, see what's provoking it, see what's making it feel better, do some manual therapy perhaps. Um, and then we would see, okay, we've tried everything. We've tried limiting range of motion. We've tried decreasing load. We've tried uh, decreasing proximity to failure. We've tried exercise selection. We've tried other exercises. We have taken the deload. We are getting acupuncture. We're getting this. And it's just not working. Uh, First, I would probably refer to a doctor, and they would take a look at I forget what I said, a shoulder, I think. Look at the shoulder, maybe get some imaging in there. Uh, then at that point, I would probably say, hey, maybe we should come out of this deficit. Um, Maybe I would talk about the deficit once we decided to take the deload, now that I'm thinking about it. Throughout that little process that I just explained, I would probably go with a deload around the same time as the referral to the orthopedic, and then also maybe go to maintenance if they're in a deficit. If it's like a significant deficit, then I would say let's go to maintenance for a little bit and see if that helps because we're going to deload, which helps physically and mentally, and then let's just give you some food, see if that helps, and then we'll kind of go back into it. That actually happened with me in 2022 when I competed last. I worked with Jeff, with us here at 3DMJ, and I developed this nasty foot pain, like right in the ball of my foot, because to get my steps in, I would go for like a long walk with my daughter in the stroller because at the time she was under a year old, I think, or just over a year. I would go for these long walks with her, uh, go to work, come home, and then I just needed more steps. So I would, there just weren't enough minutes in the day to go for another 40-minute walk. So I would do like a 10 or 15-minute, like high intensity kind of thing. I would like do high knees in place just to get the steps and get the cardio in. And I developed this, I was usually doing it in socks because I was in my living room or dining room. So I developed this nasty, nasty pain in the ball of my foot. And at the same time, or around the same time, swelling in both of my legs, like Michelin man swelling. Like touch my lower leg with your finger and like gully, like just an indentation in my leg. So when that all started happening, Jeff said, I happened to be going away on a weekend trip with my family. He said, eat at maintenance, don't track for these next couple of days. And I was like a month out from my second show of that year. So he was like, don't track, just relax, eat, don't do extra steps other than they naturally occurring, and let's see if we can get this thing feeling better. So that was the approach we took with that. But the pain was pretty significant. I could barely walk. So that is 100% like, let's calm this thing down before we start building it up. So that happened. We took a little bit of a deload in training, ate back at maintenance, although I didn't really eat at maintenance because I just had that mindset, like, let's grind. So, yeah, sorry, Jeff. No, I did. I didn't like stick to my complete deficit and I didn't do any extra steps. I think that was really what helped. I didn't go for these long walks to get 10, 12,000 steps a day. But my point is that we did look to the deficit in that instance. So I would say if we're talking about deload, then I would say let's look into the deficit, maybe come out of it and at least eat at maintenance. But not one of my first things I would go to. All right, let's see here. Acute pain, that is almost like a pickup line, the way it's written. I don't know if it was auto corrected like that, but there's a letter A space cute pain. So that is like a dad joke slash dad pickup line. I guess a dad wouldn't be doing a pickup line unless he's a single dad, which is totally cool too. Um, yeah, so acute pain, low back, right side only, no shooting or numb or tingling. Uh, QL stretch seems good. So quadratus lumborum stretch, which is tiny muscle that sits on the side of your spine, goes from the lower back onto the pelvis. Feels good, but can piss it off. Heavy hip hinge sometimes feels good. Very weird. Yeah, it's kind of a melting pot of symptoms there. Um, the one thing I'll say is, well, a few things I'll say. It's good that there's no numbness and tingling. Um, Second thing is the QL stretch. Uh, if something's making it worse, don't do it just because it's a good stretch for the lower back. Um, it's different for everyone. So a QL stretch may feel great for one person, but it may piss it off for another person. So I know you said sometimes. So if it feels really good most of the time, but then on days when it's really flared up, it just doesn't feel good. That's one thing. Keep doing it, but don't do it on those days where it's painful. But in another example, I've previously had people that come in and will stretch their hamstrings or stretch a certain kind of stretch that they heard about. And I asked them, how does it feel during and after you stretch it out? And they said, oh, it feels way worse. All right, then don't do that. Um, so when it comes to the QL stretch, just handle with care. Be aware of how it's making you feel, and if it's more often um, making it angry instead of making it feel good, then I would say hold off on it. No need to do a stretch that doesn't make it feel good most of the time. And heavy hip hinges sometimes feel good, um, which makes me think that most of the time heavy hip hinges feel bad. I would say in that instance, um, hold off on heavy hip hinging if most of the time it hurts, but sometimes it feels good. Just because the times it feels good, just like when you're recovering and you're feeling great, and sometimes your pain just comes back for some reason, no real rhyme or reason, just randomly kind of comes back. That could be what you're experiencing, but the opposite. Like it may be angry and telling you not to hip hinge heavily, but you're getting random days when it just feels good and you're kind of rolling with it, which is okay on those days. But perhaps the overall heavy hinging is maybe causing it to keep being flared up. But tough to say. Either way, uh, I think you're the way you wrote that makes me think you're thinking the right things. Um, so yeah, hopefully it still recovers and starts to feel better. How did it happen? Do you think isolation exercises for the rotator cuff muscles are necessary? I see many claiming compound exercises are enough. Um, the only time I would isolate the rotator cuff is if we can't do anything else. If we have tried every single way to load the shoulder, we've tried lateral raise, no good. Partial range lateral raise, no good. Isometrics into a wall, no good. Um, just range of motion, no weight at all, no good. Can't lift up overhead. Can't do a landmine press. Can't just slide your hand up a wall. Then I would say, okay, we need to put some kind of load into the shoulder. Let's get a band, hold it, strap it over here, and let's just see if we can move the shoulder uh, where it's below shoulder height, but we're at least getting some load in there. Other than that, or someone post operatively, if someone comes in with a post op after a shoulder surgery, then I would say not a bad idea to start there. Everyone else has no business doing any kind of isolated rotator cuff strengthening. Um, if the goal is hypertrophy, then it is the opposite of what you want in a stimulus fatigue ratio. You're getting a lot of fatigue with absolutely no stimulus. So, and not you, but just in general. Um, so many times I'll have people that do long warm ups. before upper body training. They'll do rotator cuff banded exercises. They'll do, I forget what it's called, around the world or something, where they have the band. They go up over their head, back, up, over, um, and they'll have this little rotator cuff routine before they go onto the bench. Um, that is kind of like pulling the rug out from under the bench press, because you're starting in a fatigue state already, and it's not giving you any benefit in strength or hypertrophy. So I would highly recommend not doing isolated rotator cuff exercises unless it's the only thing that we can do. The rotator cuff works as a whole. There's no movement that the human body can do, uh, other than if you're trying to do it, to isolate a rotator cuff muscle. Anytime your arm is hanging against gravity, your rotator cuff is contracting as a whole, just to keep the head in the socket. So you have the ball of the humerus, the socket of your scapula, and it kind of sits right in here. The labrum is like a suction cup on the socket that helps the head kind of stay in there, and the rotator cuff is the group of four muscles that come around it and kind of keep it together. So hanging, carrying, pressing, pulling. Any time your shoulder's moving, your rotator cuff is contracting as a team. It doesn't want to work in isolation. So I would say avoid isolated rotator cuff exercises if your goal is strength and hypertrophy. Uh, okay. The phone auto corrected the acute. That's awesome. Someone's going to use that as a pickup line. I know it. Let me know if you do. I think the SIQL thing started from my bad mattress. Flat feet and very sedentary at work. Meant to say hip hinges almost fix it. Gotcha. Um, Bad mattress, perhaps, because that is the similar conversation of the brace for the elbow pain. If you're on that mattress and it's putting your back in a bad position, if it's just not comfortable for you, then you're waking up like here, or maybe even over, right? Maybe the mattress is putting you over and you're waking up in pain, or it's waking up at night, which isn't good, right? Because we know the importance of sleep. So trying a new mattress, maybe a new mattress cover could help. Putting a pillow between your knees can help. Putting a pillow underneath your knees if you're on your back can help. Um, all those things are possible contributing factors. Flat feet, I don't think so. That wouldn't be something I would think would impact what you're saying. That being said, using an orthotic in your shoe can help. So how does that make sense? If it's not my flat feet, but an orthotic that puts my arch higher feels better, how is that not my flat feet? Um, an orthotic simply changes the way the force is being put through the lower extremity. Same idea as changing your foot position on a leg press. If having your feet like this hurts and moving your feet like this feels better, it's not that having your feet like this is bad or inherently dangerous. It's just that for some reason it's painful. And going like this makes it feel better. And then after pressing like this for a couple weeks, perhaps you slowly start to move your feet out over the course of a few training sessions, and it feels better. Same idea with the flat feet. Flat feet are totally fine to have. Most people do, and our bodies are well able to adapt to those kind of things. Just think about everything that we've adapted to over the years of millions of years of us existing. Um, Flat feet is not going to be the thing that takes us down and gives us pain. So try an orthotic if that's a concern, though, because it can help. It can help just change the way the force is being put through the leg, could help with the back. Um, you mentioned you're sedentary at work. That is a big thing too. Probably the biggest thing that we haven't talked about yet. Make sure you're getting your steps in. Walking is one of the best things you could do for back pain. Make sure you're taking breaks at work. Make sure you're changing your position in the chair at work. Um, Little box under your desk. Put your feet up. Put one foot up, one foot down. Towel behind your back for a couple minutes. Take the towel out for a couple minutes. Lean on your side. Lean on the other side. All throughout the workday. Try to do those changes every 20 minutes or so. I think that will help too. And make sure you're getting your steps in because walking is really important for back pain. And the hip hinge sometimes feels what do you say? Oh, hip hinge almost fix it. Believe it or not, that's not the first time I've heard that. Sometimes the heavier the load, the better it feels. I don't know. Maybe your pain is just a bro at heart, and it can't not lift the heavy loads. Now, what I think is happening with patients that say that is probably the heavier weight causes you to recruit maybe different muscles or in a different pattern, or maybe you mentally approach it a bit differently, and things just get braced a bit harder and a bit more stable. I don't know, um, but that's what I would imagine. But it's not the first time I've heard that. So if heavy lifting is okay, keep doing it. You want to preserve whatever you have. Okay, a follow up to the rotator cuff question. What if we have a history of shoulder impingement? Should we isolate for prevention? No, I would say no. Um, Shoulder impingement is not really a definitive diagnosis either. Um, it's commonly used. So I'm not saying like that anything against you using it as a term. I know what you mean by it, and everyone knows what that means. So it's a term that gets thrown around quite a bit with shoulder pain. But really, initially it's called impingement because the thought was that you have this tendon, you have the acromion, which is like the bump on top of your shoulder, and then you have your arm bone down here. And whenever you move your bone, your arm, you kind of like hit this rotator cuff tendon in between those two structures, and it gets pinched. And over time, it can tear and it can kind of fray and tear. But we've really found out through research that that's not a thing. Um, our shoulders impinge all the time. It's quite normal. You have structures in there that prevent it from being something bad. So I would just call it shoulder pain. Um, and if you have shoulder pain, I wouldn't say you have to isolate your rotator cuff. I think you could do whatever you can, as much as you can. If you can't do anything and the only thing you can do is rotate your arm at your side, then do it. But other than that, I would keep doing whatever you can do. Are there other things that we can do to prevent recurrence of the shoulder pain? Um, I think just approaching it with this mindset, I think is the best thing for longevity of the shoulder. Just knowing when to pull back, when to modify. Uh, yeah, that is probably the best way to do it. Having, depending on how bad it is, having the healthcare team that you trust at your disposal, one phone call away. Hey, Nick, I've tried conservatively managing it on my own. I modified this. I've changed this. I focused on my sleep. I changed my desk at work, and this thing is still getting worse. I think I need to come in and see you. Perfect. Come into PT, try some things. If it gets better, great. See you hopefully never, because it's getting better, not because I don't want to see you. And then, but if that doesn't work, then you got your higher ups. You can maybe get some injection medication. But the idea is that it's not the goal is not to be pain free in your shoulder for the rest of your life. The goal is to accept pain for what it is, accept it for what it isn't, and know how to manage it when it happens. Um, and over time, you're going to get better and better at learning the tendencies of your shoulder. Better than me, better than any doctor can do, because you're the one living with it. So if you know that certain stretches feel great, a physical therapist or an orthopedic is not going to know that. You're going to know that. So that's cool that you know your shoulder best. And you're going to find out more and more as you go. And you'll be more armed and more resilient mentally, physically to attack it next time. Whenever the pain comes back, if it does, it's approaching a different beast every time because you're not the same person you were a year ago, 5 years ago, 6 months ago. Having gone through the pain and gotten over it, you are now stronger for having done that. So that pain doesn't know what it's got coming if it comes back. Thank you, Sarah. It's much appreciated. I'll officially call it SI lumbar bro pain. I'm glad I can help. uh, yeah, no, man, that's awesome. It's my pleasure. Wow, I'm always amazed at how these things fly by. It's been an hour and 10 minutes already. I am going to call it there, and I really appreciate everyone coming out, and your questions are always so great. It's one of my favorite things to do, honestly, is to come on here and chat with you guys. Even though I'm just talking to myself in front of a screen, I feel like we're all in a room together, hanging out and just sharing stories and stuff. So it's always a pleasure. I look forward to doing this again at some point, probably in the near future. Maybe I'll get a regular cycle kind of going on, maybe once a month or something. Come on here and do some Q&As and stuff like that. But yeah, I appreciate everyone, and yeah, I'll see you when I see you. Everyone have a great rest of your weekend, and we'll talk soon.